level interventions to prevent obesity. This is moderated by Dr. Bill Dietz, who chairs the Sumner M. Redstone Global Center for Prevention and Wellness, and the Stop Obesity Alliance at the Milken Institute School of Public Health at GW University. I'll hand things over to Dr. Dietz to introduce the panel.
Great. Thank you. It's a pleasure to be here and to be a part of this panel. Before we get started, I think it's worth mentioning two recent publications from the Cochrane Library on interventions to prevent obesity in children aged 5 to 12 and 12 to 18 years. These were a review of hundreds of RCTs of diet, physical activity, and the combination of diet and physical activity that found really minimal outcomes, positive outcomes, which I think circles back to the need to emphasize, as we have today, the importance of a systems approach. Because I think that repeating more RCTs means just doing the same thing over and over again and expecting a different outcome, which, as you know, is a form of insanity. So today we're going to be spared that repetition with the presentations we have, beginning with Deanna Hoelscher, who is from the University of Texas Health Science Center at the Houston School of Public Health in Austin, who will talk about Texas CORD, lessons learned from primary and secondary childhood obesity prevention. She'll be followed by Boyd Swinburn, who's from the University of Auckland School of Population Health, who's going to talk about lessons from Down Under. And I should mention that I was pleased to co-chair the Lancet Commission on Obesity, Undernutrition, and Climate Change with Boyd that you heard about from Vilma earlier today. And the third panelist is Bob Vollinger, who's at the Centers for Disease Control and Prevention, who's going to talk about the ASSIST program, shifting the paradigm for tobacco control in the US, a policy and media approach with results. Next slide, please. So my only disclosure is I'm a consultant to the Roundtable on Obesity Solutions of the National Academy of Medicine. But I suppose I should also disclose that I was the director of the Division of Nutrition, Physical Activity, and Obesity for 16 years at the CDC, during which the NCORE was established 15 years ago. And it is astonishing and revelatory that this the NCORE has continued and to have been as successful as it has been. Next slide. So I just wanted to come back to the issue around systems to share with you the Roundtable on Obesity Solutions Causal Systems Map, which was developed by the Roundtable on Obesity Solutions under the auspices of the National Academy of Medicine to show you just how this complex system has provided real insights on the part of the Roundtable and has allowed us to focus on three major strategies, again, defined by the Meadows criteria. And those are structural racism, biased mental models, and effective communications. So this is the latest iteration of the lineage, which began with the accelerating progress in obesity prevention, followed through the Lancet Commission, and now into the Roundtable. So I'm now going to turn it over to Deanna. Deanna?
Thank you for that nice introduction and the introduction to this topic. So I'm very pleased to be part of this to cover some lessons that we learned from our Texas CORD. So next slide, just a few disclosures. I just wanted to mention that we do receive royalties from Catch, but all of these go back to the university, so they don't come to any individuals. Next slide. Oh, great. And I'd also like to acknowledge the investigators on this project. So I was a co-principal investigator with Nancy Butte. And then you can see the list of co-investigators, several of whose work I'll be mentioning today. This study was funded by the Centers for Disease Control and Prevention as part of their childhood obesity research demonstration projects. So we were part of the first round. And then we had a variety of partners in the community. So what I'm going to show you today is a way to kind of operationalize a systems level intervention into communities, Houston and Austin, Texas. So next slide. So just to tell you a little bit about our study design. So kind of what we were looking at was combining primary and secondary prevention. So we operationalized primary prevention as efforts targeting the entire population. So this is children who are at a healthy weight as well as children with overweight or obesity. The goal is prevention of child obesity, and it involved both environmental and programmatic changes. And we relied on social cognitive theory and the social ecological model for a lot of the theoretical underpinnings here. So what we did for our primary prevention was we targeted elementary schools. We worked with them. We also worked with early care and education centers. We also did some work with primary health care that I'll be talking about. And then we did a training for community health workers where we talked about policy. With the primary health care through the clinics, we had a referral system that went to our secondary prevention program. So the secondary prevention program were efforts that were focused on children with overweight and obesity. So the idea was to prevent disease progression and development of comorbidity. And these were more intensive programs with more contact hours that included the parents more in a more intensive program. We use social cognitive theory here, but we also use motivational interviewing as theories underlying this. So we actually see this as a continuum where you go from the community to the providers, and along the way, there's a coordination. Next slide, please. So as I had mentioned, the families enrolled in this program were in both Houston and Austin. So we did an assessment of the areas, and we sought to find communities that were matched. We had a control and an intervention community in both sites, in both Houston and Austin. And we looked at the catchment area to look at percent at the federal poverty line, home ownership, racial, ethnic diversity. So we looked at a variety of factors to match these communities. And as you can see here, if you look at our Head Start second grade and fifth grade cohorts, what you see is it was primarily Hispanic or Latino with a sizable Black or African American population. The majority had an annual income that was less than $25,000 per year, and the majority of them were enrolled in Medicaid. If you look at the bottom graph, you can also see that it's a very high prevalence of obesity. So this is definitely an area where there was a need for these kinds of programming. Next slide. So I'm going to take you through each of the areas that we focused on. So the first one is the early care and education centers. And so we implemented Catch Early Childhood in these programs and the intervention centers compared to the comparison centers, which did their usual programming. And so what we found is there was a decrease in child BMI score and percentiles after 2 years of implementation. So these were Head Starts for the most part that we implemented in. We did not see changes, however, in diet, physical activity, and sedentary activity, and these were reported by the parents because we were dealing with preschool kids. We also found through this work that we had high implementation of the program in intervention centers. There was, however, some contamination and some implementation in comparison centers. What we find is with these large implementations, people talk to each other, they transition from one center to another, and sometimes they bring the program with them. So it's difficult to totally do away with that contamination. But the program was fun and easy to implement. The children loved it, and the parents loved it as well. So the next group I'm going to talk about is the schools. So in the schools with the primary prevention intervention, we did catch. So next slide, please. And so what we did there was we did teacher training and boosters, and then we did the Catch Elementary Coordination Guide. And so this guide was set to match the school calendar. So it gave activities to do throughout the year so that you could coordinate at the school level. We also offered technical support with visits and emails, and these were to the intervention schools. So we looked at outcomes for 2nd and 5th grade students, and what we found were that there were no differences when comparing intervention versus comparison. However, when you looked at the grades that were combined, we did see some significant findings. Again, we had an issue with contamination because we were in the same school district. But one of our more interesting findings is that in schools where there was high implementation, we got better outcomes than moderate or low implementation. So it was really related more to implementation rather than whether they were allocated to the control or intervention groups. So the next part of the intervention was about clinics. And so with clinics, the next slide, please. We really focused on getting the clinicians to implement brief counseling and then screening for overweight and obesity among the kids. We also had developed a series of resources that we used, and we found that these improved provider self-efficacy and counseling. And we also were able to develop an implementation index to look at how well they were implemented. Next slide. As I mentioned before, once they were screened, they were allocated to either the usual care, which was the Next Steps program, or our cord secondary prevention program. And we had different programs for preschool kids versus 6 to 12-year-olds. So the preschool children met had one meeting a week for 10 weeks, and then 9 months post-program where they received cooking lessons, role model stories, and then they got text messages. For the elementary school children, they received the Mend Catch program, which was twice a week for 10 weeks. And then they had a 9-month post-program with the role model stories. And then they also had cooking classes, and they were transitioned to YMCA sports programs. So at the next slide shows some of our outcomes from that. So basically what we saw is there was a significant group effect, intervention effect among kids who were 6 to 8 years old. We also saw a not near significant effect for those who were 9 to 12-year-olds. With the 2-year-olds, we saw a time effect, but not an intervention effect. So the next slide shows some more of what we found. And really, one of the big lessons that we learned in the next slide is that in terms of the dose, we found that intervention dose was very important. So with our Next Steps program, which was what happened with the provider, so when the provider did counseling, and they were advised to go back for counseling, not everyone did it, we had very low dosage compared to MinCatch, but even that was low. So as you can see, the total overall attendance was 52% of the program. And what we found is if the children and their parents attended 20% or more of the classes for 9 to 12-year-olds, we saw a significant decrease in the percent BMI 95th percentile. With 6 to 8-year-olds, it was 50% attendance. With 2 to 5-year-olds, it was 70% attendance. So it really was tied to intervention dose. So the next slide shows the intervention cost. And so if you look at the cost per participant, Catch Early Childhood was a little over $26. Catch Elementary was a little bit over $1 per child, but there were many children involved. So the total cost tended to be on the higher end. The secondary prevention, though, was very expensive per child. And part of that were the resources involved in terms of personnel. So the next slide highlights lessons learned. So first of all, we see that primary prevention programs can decrease BMI in preschool children, but the effects on related behaviors are mixed. Implementation of program really influenced results in elementary schools. And the intervention tended to be more effective in the early care and education centers than in the secondary prevention. The secondary prevention tended to work better with elementary school kids, and the effects were greater with greater dose. And then one of the things that was mentioned by Ross Hammond is when you combine these both primary and secondary prevention in a large urban setting, it was hard to make those connections, and you really needed a coordinator or a convener. So we think it might work better in a smaller, more contained section. And then the next slide, the final slide, is just other things that we learned is you really need strategies for implementation. These are ways that you can address health equity. And then finding a way to reduce barriers to attendance is important, especially for health equity. So thank you very much. And there's my contact information in case you need it.
So I'm unable to start my video, but Boyd, on to you.
Thanks very much indeed, Bill. And yeah, congratulations to NCORE, 15 years. That's fantastic. I was involved early on, and the work from the early days of NCORE led to those Lancet series on obesity and the Lancet Commission. So I think the NCORE has a lot to be congratulated for. So next slide is just my disclosures, which I have a bunch of research projects, all from government or philanthropic sources. Next slide. So I'm basing this talk on my experience involving in more than a dozen community-based childhood obesity interventions in a number of countries. All of these are 3 or more years in duration, largely quasi-experimental, and all of them had kind of measured BMI outcomes. But as Chris did, I'd like to just trace the evolution and thinking about prevention programs and focus a bit on this capacity building approach, which we used in multiple interventions, and then moving to the systems thinking and combining it with Indigenous approaches. Next slide, thanks. So the sort of paradigm, I guess, that we're looking at in a kind of a linear fashion is depicted up there. And next slide shows that most of the interventions so far that we use are these package delivery approaches. Next one. This is where somebody comes along with a package of goodies. And next slide, and there's all the dollars and the interventions, and that lasts for as long as the grant lasts. And then next slide, it disappears. And I'm afraid a lot of the studies are like that. The next slide shows that, yep, and the next, thanks. Shows that most studies are like this, but they're not sustained. Next slide. Bill mentioned the latest Cochrane review on obesity prevention. So this is nearly 250 studies, mainly cluster RCTs, mostly in schools, mostly in high-income countries, mostly less than 9 months or 15 months. And showed very little impact. And I think this is a failing of how we think about the problem of obesity prevention. And please, let's not have more short-term, limited package delivery interventions that just add to this null effect that we're seeing and kind of give obesity prevention a bad name, really. Next slide. So knowing that this package delivery is a problem, when we're conceptualizing what we wanted to do and working with communities, we took a capacity building approach using the WHO building blocks of capacity building, leadership, building relationships, mobilizing resources, upskilling people, monitoring and evaluation. Next slide. And we did this in 3 communities, and this is a decade or so of work, all condensed into a single slide. So the one at the top, the Romp and Chomp, which is the under 5, so that was actually the last one that we did. And by that stage, we'd run out of money, and we couldn't kind of get too much money to try to prevent obesity or prevent the increase in obesity in 12,000 children in Geelong. We only had $100,000. But in the end, we actually were able to do that and show significant decreases compared with the rest of the state. And that was an important set of lessons for us, which I'll talk about. The one in Colac in primary school aged children, that showed significant reductions in waist and BMI and weight over 1 year, over 3 years. And then interestingly, we went back 3 years later, so that's 6 years after the start of the study, and we found that in the intervention site, the obesity levels had remained down, and the community was continuing to do quite a lot of activity. But in the comparison areas, which was the region around this town called Colac, they had heard what happened through the grapevine. They'd mobilized their own resources. They had taken this on as a priority, and the results, the reduction in obesity was occurring also in the comparison area. So this was kind of a spreading influence. And then the third one was in secondary school aged children. So this was largely a school-based project rather than community-based. And again, over 3 years, reductions in obesity compared to comparison schools. And these are all in rather low income, largely white, rural and regional areas of Victoria and Australia. So next slide, thanks. So just picking up on the lessons from Romp and Chomp. So this was the last one we did, and I said that we didn't have really any money, and we tried to do stuff at scale. And we did that in retrospect, I have to say, by reorienting existing systems. And when we look back on the notes and the minutes of all these meetings, there was a lot of argy-bargy and shuffling and jostling and between the organizations about who is going to do what and so on, because there was no money to pay for anything. We had to reorient what existing organizations were doing. And it's when we came along and reanalyzed this retrospectively with the knowledge now of systems science through the Compact program that both Chris and Ross mentioned, that we realized that we were taking a systems approach without really naming it as such. And particularly this intervention spread from the steering group through the networks, and this transmission of the knowledge and engagement through the networks was a really important theoretical base, I guess, to make sense of what was happening within Romp and Chomp. So I think this was really instructive, trying to do stuff without much money at all. Next slide, thanks. From the Be Active, Eat Well, this is the primary school age kids. We found no negative consequences that was feared, perhaps, around eating disorders or whatever. We found it was pro-equity. It helped the poorer kids better. But this spread of the intervention, this knowledge and engagement through the networks, this kind of prevention virus out into the comparison areas, which were all around this town, really tells us that this kind of self-starter approach is probably more sustainable than a bunch of project funding, which comes in either through research or through health services or whatever, and then that funding goes. So that was an important lesson for us. Next slide. The intervention in the high school kids, which we took in Australia, which is that left-hand area, we also adapted it and intervened in Fiji, where there's the indigenous population and the Indian population, in South Auckland, which was largely Maori and Pacific population, and in Tonga. And so you can see that on the left, Australia had that significant reduction in the intervention group compared to the comparison group. But in these other countries, there was really no effect at all. In fact, in Tonga, in our intervention group, the prevalence of overweight and obesity went up by about 10% over the time of our interventions. So this was a real blow. This is really null and sort of opposite results to what you'd expect. Next slide, thanks. And so we really are scratching our heads here about what the issue was. And this, again, the system science approach, system thinking approach tells us about the criticality of context, and especially cultural context. While we tried to culturally adapt, it really needed to be culturally centered. We did learn that adolescence can lead community change, but really different approaches are needed for these high prevalence community interventions, taking into account the culture and the systems, leadership, maybe longer duration, how the whole thing is framed, definitions of success, and so on. So it's a complete rethink. And by that stage, I was saying, okay, I've done my bit in community interventions. Next slide. And I was kind of stepping out of that. But then we started learning about systems approaches to include culture and nature and the context and so on. Next slide, thanks. And then we started doing some work in Hawke's Bay, this project called Nourishing Hawke's Bay, He Wairua Tō Takai. And He Wairua Tō Takai means the spirit in the food, the spirit, the cultural meaning of food, which has been our kind of catch cry, I guess. Anyway, Hawke's Bay is a region of New Zealand. It's the fruit bowl of New Zealand, huge growing area, but high poverty, poor nutrition, obesity, high Maori population. And there was a program getting underway around childhood obesity prevention that I wasn't really involved with, and that became kind of stalled at the first base. And I was asked to come and take over it. And so I went right back to the beginning, and we asked the community about what we should be doing in this community, asked community leaders And the approach that we've been taking is joining up Mātauranga Māori, which is Māori knowledge, with system science methods, and using a bunch of projects within that around the systems mapping that you've heard about, evaluating a free school lunch program, which was a big intervention, and rangatahi are adolescents. They developed some eating and wellbeing guidelines. Next slide, thanks. So we did cognitive mapping interviews, and these are sort of one of the tools in the systems science toolbox to map out what the community leaders were telling us. And this is just one example. There's sort of cause-effect type of mapping. Next slide, thanks. And that gave us these PO, or the principles by which we should be intervening. And so obesity has now disappeared. We're not talking about obesity. We're talking about food security. We're talking about supporting the cohesion and integration of what the community is already doing, working with the community. Children's Hauora is children's health in the broadest context, not just obesity. Start with schools and Mātauranga Māori, bring in Māori knowledge. Next, thanks. So we did the usual community group model building, but this time bringing in strong Māori concepts and 2 Māori presenters translating it, talking about it, putting it in the Māori context, as well as the usual systems mapping. Next slide, thanks. And the the way that we kind of ended up joining up this Mātauranga Māori, this Māori way of thinking and system science, which are very, very compatible, we kind of wrapped the Te Ao Māori, the Māori worldview, and the approaches that he used, Purako, which is the narratives and metaphors, and the Mātauranga Māori, all the processes, the welcoming, the relationships that are honoured, and that sort of thing. We wrap that all around the group model building tasks. And I think that is a great way to engage people and to get the right outcomes from this process. Next, thanks. So one of the things we did do was the rangatahi guidelines. We got the adolescents to develop their own eating and well-being guidelines. We gave them the best of international guidelines and a lot of presentations. And over a period of 3 workshops, they developed their own guidelines. Next, thanks. So I'm just going to quickly rattle through some of these. So these like sustainable eating, let's build the Maori. Maori is the energy and life force of the environment and protecting the planet and so on. So that was one. Next, building in physical activity, enjoy active outdoors, experience the Maori of the whenua, that's the land and the water and the environment. Next, bringing in screen time, look up from our screens and see the real world through our eyes. Next one. Tūranga Waiwai, let's connect with our Tūranga Waiwai, which is a place we belong and feel safe, where you have rights and responsibilities. Next is showing respect, treating others with respect, and finishing, next slide, with a whakatauki, a saying about chasing your opportunities and striving your goals. So we started off with obesity prevention, and these are the messages that these kids wanted to get out about healthy eating and nutrition. Next slide, thanks. So just to wrap up, I think we need the future directions. We need to bring the system science methods to the community actions rather than try to force community interventions into RCTs and the research funding models. Co-develop the actions and bring in Indigenous knowledge and processes. I think that we need the system science methods are fit for purpose, longer duration, broader definition of benefit than just obesity prevention, and this active network dissemination. So culturally centered, community partnered, and systems evaluated. Kia ora, thanks very much for listening, and I look forward to the discussion.
Thank you, Boyd. Now on to you, Bob.
Great. Thanks very much. Good afternoon, everyone. Thanks very much for the invitation to be part of the session today. Appreciate it. I'm going to be taking a little walk down memory lane. For those of you who've been around for a while, you'll be familiar with the ASSIST program, which is the American Stop Smoking Intervention Study for Cancer Prevention that NCI supported. But I'm going to try to go through some of the background fairly quickly. Next. So I have nothing to disclose, but I did want to highlight these two monographs for you, monographs 16 and 17 in NCI Tobacco Control Series that are both on the ASSIST program. Next. So if I were doing this presentation 20 or 25 years ago, it really wouldn't require any background or information about the model and the framework for ASSIST because everybody in the field was familiar with ASSIST. But I know that was kind of ancient history and a lot of time has passed. And many of you are new to the field since ASSIST was developed. And now we're talking about its much broader application and how the ASSIST program is relevant to work in a lot of other public health fields, including obviously obesity prevention. So I'm going to breeze through this pretty quickly as far as the background goes, but just to show some of the connections between tobacco control and public health intervention. So next. So these are the 17 states that were part of the ASSIST program. Just as a bit of background, the RFP was put out in January of 1990. NCI got 35 applications from states and DC. And then in 1991, the contracts were awarded. The program ran up through 1999, when at that point, the funds were shifted to CDC to begin the National Tobacco Control Program, which we still support. Just celebrated the 25th anniversary of that program. So next. So this is the conceptual framework for ASSIST. Pretty standard fare. I think many of you are familiar with this kind of model. It shows the interventions and the channels and the priority populations that we're trying to reach out to. But the model has been widely replicated in many different forms, and I'm sure you've seen it in some of your work. So that just kind of background there. So next. So one of the things that was happening at the time was this concept of a paradigm shift. The field was moving from emphasis on individual interventions towards more population-based interventions. And now I know in this day and age, we take that kind of for granted, and other panelists have been talking about that earlier today, because it's so central to what we do now in public health interventions. But at the time that ASSIST was happening, this really was the mantra for what was going on and talking to people and training them about the importance of shifting the paradigm to population-based interventions. And obviously, it's very relevant today for this meeting that we're having here now on population and policy and environmental interventions. So next. So I think folks are very familiar with the community guide. We tried to make sure that everything that we were doing was based on the evidence, and the community guide tried to articulate the interventions for which there was the strongest evidence. I'm sure everybody's familiar with this, and the idea that the community guide was developed collaboratively and compiled a very strong evidence base that both practitioners and advocates learn to lean on and use to develop their plans. So next. So the challenge for ASSIST, there really were several different challenges, but things like building a multi-level network, creating a strategic plan, defining the goals, teaching skills, and including the much needed resources, and then how to overcome barriers. So there was a huge range of diversity in where the states were coming from and what their capacity was. And no state that was part of the ASSIST program had a full infrastructure, nor did they have all the resources and skills that they needed to plan and implement this approach to tobacco control. So we had to help them, train them to educate people about what policy change was before they could begin the process of mobilizing people. But those were kind of instrumental steps of the process. So next. So this is just a little bit about the organizational structure. I'll kind of go through this quickly, but as you know, NCI brought the research base, the staff, and the funding for the program. Our partner, the American Cancer Society, had a strong network of people who were committed to preventing cancer and tobacco use and who could advocate for policy change. So that was one of the things that was really essential, to have a private partner that did not have the same constraints on their funding that government funding has. And then, of course, we had a very well-skilled and coordinating center that brought together a lot of the skills and the people that we had. They conducted regular trainings. And then the critical components, of course, were the state health departments, as well as the state level tobacco control coalitions, and also many community level coalitions. And I heard Chris mentioning the importance of coalitions before, and that was certainly something we found here in ASSIST. So next. So the strategic plan, basically, again, just the importance here of emphasizing training and technical assistance, and all the things that were provided through that training and technical assistance, and the conferences that we did, the materials that were developed, and then being able to modify and adapt those so that they fit the needs of the particular populations. So next. So the program was focused on the policy, media, and program services, and this really was the heart of the paradigm that ASSIST had. Often references the three-legged stool, but the idea was to change social norms of tobacco use by educating the public and the decision makers, working through the media, and doing that to change the policies that were in place that guided people's behavior. And then by changing the policy to increase the demand for program services, whether that was cessation services or a whole host of other things. So that really was critical. Worked very closely with folks to do extensive training on media, trying to benefit from positive news coverage that you could work to get, and showing how they could do that, kind of creating newsworthy stories and events, and offering those to the local outlets in the respective markets where the program was intervening. And then did a lot of work on training around media advocacy. And I know now we kind of think about this as something that we take for granted at some level, but then it was kind of an innovative tool that we were using. So media advocacy is a strategic use of any form of media to help advance an organization's objectives or goals. And in this case, it was working with media as a tool, not an end in itself, but rather a tool to help achieve the goals of the program. And the organization frames the issues to help show the importance to the respective communities. So next. So again, the importance of educating the public was crucial, right? This is one of the things that was happening throughout the program. And then kind of disseminating information both to the public and working to educate policymakers, and then with the private partners, having them lobby policymakers. These are some of the tools that were used here. And next. So again, talked about at the time, these tools that were used were considered new. They're not really new anymore, but the take-home message here is that you have to work to get earned media. It doesn't just happen because everybody else thinks what you're doing is interesting, but what ASSIST focus on is the ability to teach these skills, which is what we did in the program. So next. So in here, just kind of basics about strategic use of media, things that folks here probably are familiar with, about the importance of hard-hitting, clear messages, being consistent with the messages, being able to respond as quickly as possible when media requests came in. And then, I don't need to tell folks about the importance of countering messages, conflicting, misleading, wrong messages from the tobacco industry. So that was something that had to happen on a regular basis, and keeping folks focused and getting feedback from the media tracking that we were doing. Next. So, and I'm gonna go pretty, just hit a couple of very high-level points about the evaluation of ASSIST. Again, that whole second publication was about the evaluation of ASSIST. But so next, just a couple of take-home messages here about the policy change was associated with the final outcomes. So all the states that had higher initial outcomes, their policy scores had lower cigarette consumption rates and lower tobacco use prevalence rates. So both consumption and prevalence were lower in states that had higher policy outcome scores. So next. So an assist contributed to these final outcomes. So the quantitative evaluation showed small but significant program effects on the final outcomes. So assist states had a greater decrease in adult smoking prevalence than those states that were not part of assist. Those states with stronger tobacco control programs had lower cigarette consumption, and then states with higher capacity scores had lower cigarette consumption. So next. And the point here is just about how crucial capacity is. And there's lots of different ways to talk about that or to measure capacity. But some of the things that were really instrumental that we learned early on with this program was about how important interagency relationships were, the infrastructure that happened in the health departments. In many cases, the ASSIST program, the funds that NCI provided, created this infrastructure. And we learned time and again how important that infrastructure is. And then also the coalition structure that we were talking about, as well as the staff experience and the training that was provided. So next. So I'm going to go basically to kind of a couple examples of things from the individual states, but we don't need to go into the details about that now. But here you just see some of the challenges the states had to deal with, including their political climate, industry interference, the challenges of in a bureaucracy of hiring staff, and often they didn't have the right skills, so we had to get them trained. In some ways, the times are really similar now in the debates that we're seeing, particularly around health equity and what the huge divergence in what's happening in states now. And those same kinds of problems were dealt with before, but ASSIST happened at a time where the tobacco industry had a much greater influence, and so had to respond aggressively to the things that they did, had to develop materials and resources to share, and then to be very flexible. So next. So okay, I'm going to skip over a couple of the specific tools here, but the coordinating center that we put in place really did teach a lot of the lessons that folks needed. One of the things was just the importance of responding to FOIA requests. And then next. And then legal tactics. And again, lawsuits now have become a regular tool that public health people use to intervene and to make progress in some of the policies. But this was relatively early on. One of the examples here was that Philip Morris had been convicted of not reporting their lobbying expenditures, so that was highlighted. So next, just wanted to mention the importance of community engagement, and I think everybody here understands why this is so important. But it really, the community engagement approach is consistent with human rights and social justice perspective. Next, so the goals of community engagement are to build trust, enlist new resources and allies, create better communication, and improve the health outcomes while making sure that we're building successful projects into lasting collaborations. Next. So basically wanted to get to the legacy of ASSIST. This was a national multi-level infrastructure with the capacity to deliver population-based tobacco prevention and control. It really did break the model for what the tobacco industry had been doing in their monopoly that they had had on the media. And then, of course, it was based on evidence-based interventions. So next. So what ASSIST did was to provide the nuts and bolts of tobacco control. It focused on upstream indicators as goals, and it showed both an inside and an outside game, working with and through the media to make media and policy advocacy techniques, and then also community organizing and mobilization. So next. So here are the key lessons from ASSIST, and this is what I wanted to wrap up with here. So policy change is essential to having a real impact. We know that, and that's hence the whole purpose of the OPUS program is kind of capturing the progress we've learned over time. Partnerships are key. It's essential to have all the right people in the room and at the table when you're working to advance these goals. And then working at the local level really does make a difference. The whole issue of preemption is critical. We need to make sure that that people are allowed to do their work at the local level, closest to where the people are. Assist was the first example to bring federal resources to the state and local level to focus on tobacco use. Again, the infrastructure and training were essential. The training and technical assistance really have to be current. You can't just take something out of the box and disseminate it if it's not current and relevant to the audiences that are at play. Again, the coalitions have to be working together towards a common goal. And then here, the emphasis or mention of multicultural priorities is important, but I think that has evolved so much that really now our health equity and DEI efforts really have to be front and center. And we've learned the hard way that if we don't be really comprehensive and thorough about that and proactive about reaching out to partners, that we're going to really miss the boat. So I think I'm out of time, so I'm going to wrap up there and leave it for our discussion, but I'd be happy to talk to folks afterwards if I can help answer other questions.
So I'm unable to start my video. Okay. Great, thank you. I wonder, yes, thank you for turning us all back on. Excuse me, Boyd. I'd like to begin with you. I think you left a lot of confused attendees in the wake of your presentation by the use of the term argy-bargy. Could you please provide us with a synonym for that expression?
So argy-bargy at the time when we had local councils and health services and kindergarten agencies, and we said, okay, we've got to work on this, and they say, no, well, that's not in our program, we don't have people for that, we don't have budget for that, and that's your job and this is your job. So there's a lot of jostling of roles and responsibilities when there's nobody's coming in and putting a plop of money on the table and saying, okay, this is for achieving this mission. It's kind of reorientating everybody's organization to a new sort of position, or applying resources and effort in a particular direction, and that takes changes in organization. So yeah, that's the argy-bargy of it.
Yeah, thanks. So a more serious question is, you said you were brought in for the Hawke's Bay work from the outside. How did you establish trust as an outsider?
By starting from scratch and working with the Maori leaders, yeah, just being able to go with people who had the status within the community and start from scratch by asking them the questions about what they wanted to achieve from such an intervention. So yeah, it was going back to square one. I think for a lot of communities, wandering in and putting obesity prevention or obesity on the table is a bit of a turn-off. And so we do need to look at ways to engage them on their terms and for the issues that they see as important in the way that they see it. So they quickly shifted us to, as I said, children's haora, which is overall health and well-being. It's mental health and spiritual health and physical health and things. And so you just have to go. You have to go with that flow. That's their terms.
But you were a stranger to that group, were you not, or did you have some credibility already?
Well, I've got a little bit of scientific credibility, Bill. Which
I'm not talking about the scientific credibility. I'm talking about the cultural credibility.
Yeah. So this is why I had to partner up with Maori leaders who had serious standing within the community, and they said, medical doctors, leaders in the area, and said, this is really important, and opened the doors and managed the whole community relationships, which is so critical.
Great. So here's a question from the attendees, and I'll direct this to you, Bob and Deanna. Do you have any suggestions for an assist-like model for nutrition or physical activity or obesity prevention overall? What are the policy levers? I mean, how how do we mobilize the same resources that worked for ASSIST for obesity? Because I believe that obesity is a much more complicated problem than tobacco. So could you comment on how we mobilize the political will necessary to address obesity?
You know, the political will is always the challenge, right? It's trying to get people lined up to do something of this magnitude and scope. And I think, you know, when ASSIST was conceptualized, things were very different now. But I do think that people understand the consequences of the health consequences of obesity and its sedentary lifestyles. And so to try to tackle that is trying to get people lined up who are willing to do it, and then, you know, a funder who's willing to make the investment. That was the thing that was unique at the time for NCI to be willing to come up and put that amount of money on the table. But there are a whole host of interventions that would be relevant, right? Everything from, you know, the built environment they're dealing with, you know, programs to get people moving more, you know, the Let's Move program, those kinds of things, as well as, you know, in an earlier presentation today talked about sugar sweetened beverages, right? And there are places that are adopting those kinds of policies. So there's a whole kind of panoply of interventions that can happen. The question is how to get folks together to act on that.
Deanna, anything to add?
Yes. A few years ago, we did a survey of state legislators. And, you know, one of the things we found is what we think of as levers, they don't see the association between that and obesity. So, for example, when we ask them about, you know, like farmers or transportation policies, they didn't see any connection. So you have to find an alternate way to promote those policies. They did see the connection between a medical model. So the medical model was easier for them to see than the public health model. The other thing we're doing right now is a project called Research to Policy Collaboration. And so what we do is we interview state legislators and we ask them about their policy priorities. And then what we do is we try and find state level data that kind of support some of the policies. So maternal and child health policies in terms of obesity prevention tend to be more popular with them, and then school-based rather than anything that would be adult focused. But we're in a very conservative state, so the child and maternal health seems to resonate better than adult-oriented policies.
So what is the role of stigma and bias associated with obesity and the inability to mobilize resources? And I'd be interested in a response from all three of you. And Boyd, whether that's as big a problem in New Zealand as it is in the US. I don't think that same stigma and bias applied to tobacco users until quite recently. I mean, it was not a stigmatized condition. It was a widely accepted practice.
Yeah, just to answer your question about whether it applies in New Zealand, it does indeed. I think weight bias is very pervasive, and from what I understand from literature, seems to be heading in the wrong direction, getting worse, whereas other sorts of stigma and bias may be getting better. In New Zealand, the populations with the highest amount of highest prevalence of obesity are Pacific populations and Maori populations, and they do have a different body size perception or tolerance of larger body size as being appropriate body size. So so within their own communities, there's that greater tolerance of a larger body size, but the wider societal weight bias is still pervasive, and I think it's institutionalized. And that's a real problem, and that's a big part of the O word, of putting the O word on the table. It's communities react negatively to that, and we have to manage that. We have to deal with that and operate on their terms, I think.
So Boyd, another question for you. How could the culturally centered approach that you developed around the Maori in Hawke's Bay be applied to U.S. communities?
Yeah, that's a good question, Bill. And so the context that we have in New Zealand around Indigenous populations, we have one Indigenous population, Maori. It's now almost 20% of our population. They have a single language. They are politically very astute. It's a whole different, and they have their own spaces and places that they operate, and strong networks and things. So it's quite a different deal to working with other Indigenous or other non-white cultures, I think. So we have been doing some work with New Zealand and Australia, North America, Hawaii, working with various groups of us working with different Indigenous populations. We just had a big conference in New Zealand with people from Wyoming and Montana came down here to exchange. This is Native Americans to come and exchange with Maori. So I think these networks are improving. But from what I understand, especially from the Native American position, they are quite different in terms of the degree of political power, the degree of, I guess, cultural. So for example, language within New Zealand, we've got a high proportion of Native Maori speakers, whereas these Native American populations from North America had very low local use of local language. The whole cultural lift up is a bit further behind. So I think it's a real challenge. You've got Black and Hispanic populations as well. This is what Ross was kind of talking about earlier, that these local contexts are so critical that you have to go down to that local level and work with the people there and build it up from them. I mean, for those studies we did in Fiji and Tonga and South Auckland, where we sort of took the approach that worked in the white Australia and tried to culturally adapt it and so on, it just wasn't enough. It didn't come from them per se, and so it's all about long-term relationship building, I think, and working with them on their priorities.
Yeah. So Deanna, two things. Some of what Boyd was just describing applies to Hispanic populations and the need to make culturally specific interventions or discussions. So two questions. One, was that an approach that you took in designing the intervention? And secondly, there was an odd finding that you had around preschool kids, in which there was no effect of the intervention. There was no effect of the targets of the intervention, and yet there was a positive outcome in terms of, I think it was BMI Z score. So two questions. So
the first one, just with the Hispanic populations, and I didn't talk about that, but we did a lot of upfront qualitative work and working with partners there to kind of understand what we needed to do in the population. And, one example is you can't just write something in English and translate it to Spanish because you lose nuance. So you really should develop them both at the same time. So they're a little bit different, but they include the community context and the cultural context. So that's one of the things that we did. There are also, I want to say, a lot of positive things with working in the Hispanic community. So a lot of the traditional foods, the reliance on family that really can be quite appropriate and really add to your intervention too. So really learning what are those kind of family dynamics that help. But for your second question, what we saw is there was a decrease in percent BMI 95th percentile over time, but it wasn't enough to get intervention control effect for the first 3 months. And so one of the things that we think happened with some of it is just getting the provider to mention to the families that the children need to seek some kind of program for obesity prevention, because that's what happened. And then they came to us, and then we randomized them into the provider-based or for the community-based MEND program. So we think that that has an effect, and that's really consistent with the AAP clinical guidelines with some of the screening that they recommend there.
Great. Another
Just on
question. Sorry, Boyd, go ahead.
Yeah, just on that, Bill. I mean, I noticed that also in Deanna's presentation, and that's a finding that we had in some of our studies as well. And when you think about the logic of it, if you're doing an intervention which is across multiple domains around, you know, breakfast and lunch and junk food and physical activity, and there might be 10 or 15 kind of behavioral sort of targets, all of which have very blunt instruments to measure them. And yet BMI or weight is an integration of all of these, and it's much more tightly measured. So I mean, I think it kind of makes logical sense actually that in some cases we don't find behavioral changes, whereas the BMI may well change.
Yeah, great. There's an interesting question for all of you from the audience. Do you sense that the communities that you're working with understand the importance of a systems approach more intuitively than many researchers who have been trained in an isolate the variable approach?
I really think they do. I think one of the frustrations that people have is say you're in a program, but then you go to, if the school's not doing a similar program, you can't find the foods you want to eat. You can't find healthy foods, or they're not letting the kids go out and be physically active, or you don't have the grocery stores reinforcing this. So they get frustrated because they're trying to make appropriate choices, but they don't have help from the environment. So I think they see how important those connections are, whether or not they espouse that or not.
But Boyd, isn't that kind of decision-making more characteristic of the Maori? This kind of consensus building?
It is indeed, Bill. And a close colleague of mine whom you've met, Heke, impressive Maori guy, he was telling me about his work that he's doing in health. And I said, you need to come along to the systems science program symposium that I'm running. And he reluctantly came on, and he sat at the back and he had his arms folded like this, and he was puffing and puffing. And at the end he said, oh yeah, I know what you're talking about. That's what we call whakapapa. That's just relationships. We've been doing this for thousands of years. You know, and you come along with your fancy terminology. Yeah, we know about that. And now the guy's been to more international system science meetings than I have. You know, I think there's very it's very sympathetic, I guess, the system science thinking and indigenous or traditional kind of thinking. Do they actually interdigitate? And that's the sort of question we're asking before when we're saying, how does Mātauranga Māori and Māori approaches and system science? They're very sympathetic, but that's why when I showed that diagram, we put the system science methods in the middle, and we just kind of wrapped all of the other Māori processes and knowledge and ways of talking about things and ways of engagement around the whole process. And I think that is a better depiction of very sympathetic, but not so much interdigitated when it comes to the working on the ground.
Well, I have one last question for each of you, the same question for each of you. And that is, are you optimistic about reducing the prevalence of obesity at a population level in your lifetime?
Well, I'm optimistic. We wouldn't still be here, Bill, if we weren't optimistic, I'd say. But I take great optimism from almost all of the countries south of you. These Latin American countries are just bowling it. They know how to do this. They know how to mobilize. They're getting great policies through, and I reckon the rest of the world needs to learn from them. And it's all about community mobilization, both for getting policy across the line and for work in the community.
So rather than let the other two of you add to the downing side of this, I think we're going to close. Thank you all for your participation. It's interesting that you sponsored or sparked such conversations in the chat. This was a great panel. Thank you again.
Thank you.
Thanks,
Appreciate it.
Thank you.
Fantastic.
Take care.